Okay, look, can I very first off, just both on behalf of myself and on behalf of the board, just offer our most sincere congratulations to Roland Chesney on the award of his Queen's Ambulance Service Medal. I think that's a fantastic achievement, and I think it would be absolutely right for us as a board formally to acknowledge that and to welcome it and to very warmly congratulate him. It's absolutely perfect recognition, both for, I understand, the man he is. Unfortunately, I don't know him personally, but I've seen an awful lot of very warm comments about him, and it's a fantastic way of recognising and rewarding that service by an exceptional individual. Okay. I think I'd just make 2 or 3 further comments by way of introduction to today's meeting. I think probably just 2 further comments. First, just to acknowledge that this service, and indeed the wider NHS, is having to operate in what I think is a quite exceptional set of circumstances. In fact, I would say we're facing circumstances which none of us, even the most senior in today's audience and meeting, and I include myself in that, probably have no previous experience. Coalition government is very unusual in this country. We're not accustomed to coalition governments. And then you look at the economic and the fiscal situation that the country is facing and the impact that that has on the ability of government to fund public services right across the spectrum, but of course including the NHS and including this service. And you look at the way in which, alongside of that, demands on the service, and not just on the ambulance service, although the ambulance service is certainly included, demands on the service are inexorably rising, and one can anticipate that continuing into the future, whether that's demographics, change of population, technology, whatever it is, it's an inexorable rise. So we're faced with a situation where you can see the demands being placed on this service are going to be steadily rising. The resources we're able to deploy to meet those demands at best will be flat, and over time are likely, if anything, to diminish. And that means we need to ensure that we stay really focused on what really matters to patients and what really matters in delivering the service. We need to ensure that we work towards delivering a safe, high-quality, sustainable service for the future. Those things really do matter. And my message to colleagues consistently in the 3 or 4 weeks now that I've been part of this organisation has really been twofold. In the first place, through all the challenges that we face, whether that's the challenge of transition, whether it's the challenge of money or inexorable rise in demand on the service, stay focused. Safety, quality, money. If you get those 3 right, you can be pretty sure you're going to get most things right. But if you get any one of them wrong, safety, quality, money, you can be pretty sure that nothing is going to be right. So in all this change that we're wrestling with, stay focused. Safety, quality, and money. And secondly, operational performance and sustainability are the things that really matter. But operational performance needs not to be at the expense of safety or good governance. Those two need to work together to ensure that you've got a service which is not only responding promptly and effectively to demands and to patient needs, it's also doing so safely and in a way that's going to be sustainable into the future. Mark also that last point, sustainable into the future. There's no point in thinking in terms of plans which were going to entail breaking the bank, because there's not going to be lots of additional money available for the future. So against that, our focus needs to be very much on operational performance and sustainability, and as we move through today's meeting, I think you'll see that coming through in strong measure. Okay, let me move on through the agenda. Welcome to you all. Apologies for absence. Sue?
I don't know if you can hear me. We have Caroline Bales, Anne Osborne, Paul Remington, Rosemary Start and Dr. Scott Turner.
Thank you. Are there any new or different declarations of interest?
Yes, Stephen Day is owner and Entrusted Group Limited Director.
Thank you. Just that one. Yeah, thank you. Colleagues content to approve the minutes of our previous meeting from the 29th of May? And I'm not intending to go through page by page, but just do indicate if you have any comments or amendments.
Chair, if I may, page 10 at the top, there's a reference to ECPs on the first paragraph of emergency care practitioners. I think that should be a reference to emergency care assistants in that paragraph.
Thank you. Can we note that amendment? Thank you. Are there any other amendments? Very good. Thank you very much. Subject to that, minutes approved. Secondly, can I ask colleagues then, just turning to the matters arising not addressed elsewhere on the agenda, colleagues content that that's an accurate capture of the matters outstanding and the matters arising from our previous meeting? Again, I don't intend to go through them in detail. Colleagues content with that as an accurate record? Yeah, thank you very much. Right, let's move on then to item 6 on the agenda. And colleagues, you'll have noted my report, and I don't intend to say much in addition to that, but just to report to the board that since this was written, I have received a letter of resignation from Ms. Bales with immediate effect. She's indicated that she's finding it impossible to reconcile her work commitments with her obligations here. Her term of office was in any event due to come to an end at the end of next month. She'd already indicated to me that she would have difficulty in making next month's meeting, so it was entirely appropriate that she should step down straight away. You'll note that recruitment process for a replacement non-executive director is already in train, and we'll ensure that moves ahead as quickly as possible. I'd also just like colleagues to note under item 3, I will be reviewing the number and constitution of the board's subcommittees following the governance review by the Trust Development Authority. I think it's really important that we do ensure that this board has subcommittees that are appropriate to the focus of the delivery of this organisation, and ensure that the board stays closely in touch with the organisation in a very direct way, and at the same time has good sound arrangements for governance and assurance, so that as a board we are both able to demonstrate fulfilling our governance responsibilities and also to ensure that we stay closely in touch with the core business of the ambulance service. Are there any comments or questions on my part of that? Andrew, did you want to comment on your...
Right, yes, thank you, Chair. I think most of my comments probably picked up elsewhere on the agenda because a number of those items do appear later. Just wanted to stress the point around item 7 there, engagement. I think a number of us have been increasing our engagement with stakeholders, with partner organisations and with our own organisation. I've seen lots of ride-outs of our own senior management team with frontline colleagues. I'm continuing to go around lots of stations and offices, getting some really helpful feedback from those sessions. Really good to see our own services actually in operation. And we'll pick up some of that under item 8 later on listening into action, which appears on the agenda. So I think most of those comments, Chair, are self-explanatory. One extra bit from me, which is a sad piece of news. Many colleagues will know that Elaine Bentham, who was a long-serving paramedic with the Trust, who then went on to pursue a second career, who was a chaplain for the service in Bedfordshire, sadly died fairly recently. So on the board's behalf, I will obviously extend our collective condolences to Elaine's family, but I just thought it appropriate at this session to record Elaine's sad passing and to make sure that we pass that on to her friends and family. Other than that, Chair, that's probably all I needed to cover.
Any questions for Andrew? Comments, questions? No. Thank you very much. Let's move on then to item 7. And John, I think you're going to introduce our visitor today.
Yes, so started the quality report always with something around patient experience. Just to remind the board, we've had a run of stories. We looked at an Addison's case, a sad case where a young person died. We've looked at some of our control room functions, and we brought in a member of staff to discuss that. I'm very keen that we get both the patient perspective as well as the staff perspective. And today we've chosen to bring Anthony Shipman, who's one of our clinicians working in Essex, to come and talk to us about transient ischemic attacks and how we're doing that differently. And picking up Jeff's point about sustainability, some of what we need to do as a service is around service redesign, and I believe this is a good example of that. So I'll welcome up Anthony, who's going to come and sit here and tell us about transient ischemic attacks.
Anthony, welcome. I hope you don't feel too much in the hot seat.
Morning all.
You're very welcome. I'm delighted you're able to be here.
Thank you. I'm going to talk to you briefly about the low-risk TIA pathway for the Trust and give you a case study. For the non-clinicians amongst us, TIA is a transient ischemic attack, known in the public eye as a mini-stroke. These patients have stroke-like symptoms, but fortunately these symptoms resolve spontaneously. Previously, with our TIA patients, they were all transported to the A&E departments. Tools were used to ascertain whether these patients were low or high risk, and the low risk patients were either referred by that A&E department to their own TIA clinics in-house, or in some instances even referred from A&E back to their own GP, and then those GPs were referring into the TIA clinics. This alternative care pathway gives our clinicians on scene the ability to refer directly into that TIA clinic. The benefits to us, obviously this negates an unnecessary A&E journey, it increases the patient's experience, and it frees up an ambulance that can be left to deal with other 911 calls. The pathway itself works predominantly around a scoring system called an ABCD2 score. This takes into note the patient's age, their blood pressure, their clinical symptoms, the duration of these clinical symptoms, and whether they are diabetic or not. The tool then gives you a score out of 7, and patients that have a score of 3 or less are deemed to be low risk. Our particular criteria brings into play some other criteria based around the patient's medical conditions and their past medical history. From scene, these clinicians then ring our single point of contact, which is based here in Bedford, and this acts like a fail-safe system. The call taker on the end of the phone will go through the computer system with them and double check against all their findings so far. If they come to the same conclusion that the right diagnosis has been reached, then this patient's details are faxed from the single point of contact to the chosen hospital, and on receipt of those details at the chosen hospital, these patients are called back, given a appointment time and date within the next 7 days as per NICE guidelines. On scene, the clinicians have a TIA pack. In this TIA pack is a bolus dose of 300 milligrams of aspirin, and these patients are given it there and then. They're given the rest of the pack and told to take the given dose daily until their appointment date. There is an advice leaflet within the pack as well, and this is left with the patient should they have any problems between the clinician leaving and their appointment time. I'll talk you through a quick case study of this actually in practice. Our patient I'll refer to as John. He's an 81-year-old male who lives in Clacton in Essex. His wife called 909 discovering that her husband had stroke-like symptoms. A local Clacton-based response car was dispatched on a red 2. On arrival, he discovered that the patient's symptoms had resolved and was starting to go down the route of diagnosing a TIA. I'll read you through his notes. Patient states he developed speech problems at 0800. Focal neurological symptoms consisting of dysphagia, that's difficulty speaking, lasted approximately 30 minutes. No other symptoms are noted by the patient. Patient states symptoms have now resolved. Patient is conscious, is alert and has a GCS of 15. Airway is clear, no shortness of breath. Chest is bilaterally clear and on auscultation. There's no wheeze or crackles and the patient has no chest pain. An ECG was performed, P waves are present, no evidence of atrial fibrillation. Patient had a heart attack several years ago, but no recent history of chest pain. A full 12 lead showed no ST elevation. A full neurological assessment was completed. Patient shows no signs of focal or non-focal neurological symptoms on assessment. A full cranial nerve assessment was carried out as per guidelines and no problems noted. At time of assessment, no dysphagia. Accurate on mini mental test, no slurred speech, no difficulty swallowing, pupils and equal reactive to light. No weakness in limbs, no loss of all sensation to face or limbs, good coordination, mobilising as normal. Patient is fast negative. These paragraphs here show the depth in which the assessment's been carried out. It's worth pointing out here that the full neurological assessment was part of last year's post-qualification update. Patient has an ABCD score of 3, 1 point for age, no points for blood pressure, 1 point for speech, and 1 for their duration. He's then written down, this patient is suitable for referral to a TIA pathway clinic. All symptoms have resolved and patient states that he feels normal and patient consents to referral. Again, it's worth pointing out at this point that had this pathway not been in play, this clinician on finding these symptoms would have to call for an ambulance and then wait on scene for backup. Patient was administered 300 milligrams of aspirin orally and given the rest of the box to take 1 tablet daily starting tomorrow until seen at clinic. Patient is clear on administration instructions. Patient given full information leaflet including fast information, advised to call back 999 if any symptoms recur. Patient is advised not to drive until they are seen at clinic. Patient is advised to take his wife with him who witnessed the event. The patient is referred using the SPOC system and the referral is accepted. That patient was then left at home successfully with his wife, well aware of what was happening and consenting to this full pathway. As I said earlier, the SPOC then, single point of contact, then faxed details across to the receiving hospital, in which case was Colchester. They give them a full detail of all these, of all the symptoms. It's based on a tick box system, so that nothing's missed. Colchester contacted John that afternoon, gave him an appointment within 2 days. I said earlier that the NICE guidelines stipulate 7 days, but from the stats that I've seen, I'd say most of them are given an appointment date within 2 or 3. That patient attended the appointment, the appropriate tests were performed, and the final part of the pathway is that the clinic then sends a feedback form to our CDU unit, who acknowledging that was an appropriate referral. Okay. Any questions?
Yeah, those questions. Anthony, that's really, really interesting. Thank you very much for that. I guess my first question, I'm sure colleagues will have questions too. It's about differentiating a transient from a full stroke and the time interval. Okay, well and good in this case, the transient was confirmed and the pathway is established, entry to the pathway, and that then manages the future. But what sort of time interval can a transient sort of last for, if you like, before you'd then be saying, actually, no, this isn't transient, this actually is a stroke? And what's the correlation then with the stroke 60 pathway?
The answer to how long the duration of a TIA, I would say possibly 10 minutes, half an hour on average. I think there are guidelines that stipulate that a TIA should resolve within under 24. However, our clinicians are all trained to deal with patients that have symptoms at that time. If a patient has current symptoms, even if they appear to have started resolving already, that patient is being treated as a stroke patient. The diagnosis of TIA doesn't even come into play until that patient has fully resolved. Now, you could turn up and a patient could stipulate that they had severe symptoms when they called you, but now these symptoms are starting to get better. But the fact that they haven't completely resolved means that our clinicians are still treating these patients as stroke patients. So they will go down that stroke pathway. They will be trying to adhere to the stroke 60 targets. If en route to the hospital or on arrival at the hospital, that patient is fortunate enough for his symptoms or her symptoms to completely resolve, then that's great in itself. But we treat for the worst case scenario.
Okay. Thank you very much. Comments, questions from colleagues?
Yeah, can I ask, historically, as you said, we would probably put the patient in an ambulance and take them to hospital. How would the time on scene change from what we used to do to what we do? Because obviously the amount of checks that you listed, that takes time for the paramedic to be on scene. So how would that have changed?
There is no doubt that leaving scene and is quicker than these pathways. However, you need to look at the whole situation. It's even if this pathway takes me half an hour to perform on scene, that is significantly less than packaging my patient, transporting my patient to hospital, sitting in current delay systems within the A&E department, cleaning my vehicle afterwards. We can be looking at 2 hours in some areas, and recent examples would show even higher time. So on the whole, these vehicles are back in the system to deal with their next case much faster.
We've talked before about making all of these very positive changes, but sometimes members of the public and patients not understanding the difference between the ambulance service now and one of 10 years ago, for example. So kind of two questions really. How in Essex is this being communicated more widely so that people's expectations perhaps are adjusted? And then secondly, do we happen to know what the patient's experience was as reported to this? What was the friend and family test at the end of this one? Or generally, if you don't know the outcome for this one in particular?
I think firstly these patients, one of the important things is that they agree to using this pathway. As for the feedback, negative feedback would be relayed back to the appropriate people from if it was fed to the clinicians. I understand that there are several letters of thanks from patients on using this pathway. I'm not aware of any negative ones. But like I say, the patients that didn't agree to this system, this isn't a compulsory pathway.
No.
These patients are advised that this pathway is available to them, and if they would like to use it, it comes with a lot of fail safes on it. The clinician itself on scene, the use of a single point of contact to double check that, and then obviously these forms are then faxed across to the TIA clinics, and those details are then read by the clinical nurse specialists or the doctors there, and if they flag anything up or would like a patient seen quicker, then they contact them or contact us back and ask them to bring them in. So there are plenty of fail safes to make this a safe contact system.
Right, let me take Phil and then
Thank you. Very useful presentation. And it's just picking up on a couple of points that Margaret raised. I think from most patients' perspective, they would see this as actually a better outcome and patient experience than being taken to A&E and sitting through what's probably going to be a fairly long day and then having to come back again. And I think you in the last point you raised that there was a level of assurance around what the pathway meant, what assurances they would get and so on. Because I think in some instances people would be fearful that they would get another attack and they wanted some assurance that that the TIA clinic would actually be intervening at an early stage. But do you give a reasonably comprehensive view about what the clinic was likely to do for them, what investigations would be undertaken? And I'll give you a case in point. I had a friend who actually did have a TIA, ended up in A&E. This is probably before we started to look at this innovation. And he ended up with an endarterectomy, which I hadn't realised what it was. I now know, and it's about scrubbing out the plaque between the forks of the carotid artery. And he said that that was diagnosed whilst he was in A&E. Would the TIA clinic also undertake that sort of work to pick that up?
Yes, is the answer. I believe that there's a brief outline of some of the things that will occur at the TIA clinic in the leaflet. Many of the clinicians that are taught this pathway are aware of what happens at the clinic as well and can relay that to the patients. The TIA clinics are, A&E will run a series of tests occasionally at their discretion, but there is a set code of tests that are run at the TIA clinics. And regarding your friend, I know that carotid Doppler testing is one of the things that does occur, which will pick out that particular problem.
Thank you.
Thanks, Will. Thanks, Chair. Anthony, I guess I'm interested as well in this feedback to staff, because obviously, from being a clinician, knowing that your patient is going to be picked up in a pathway is the important bit, and knowing that it will be in a timely fashion is important. So, in relation to your case study, are the staff fed back to, would they have known that within 2 days the hospital contacted that patient and picked that patient up to that pathway? Are we able to feed back the outcomes? Because clearly, it's a much better position for our clinicians to be able to be in to do something with the patients and access that pathway, but for them, they refer and move to the next patient. How's the feedback?
As of March this year, we have an automatic email letter that goes out to the crews that use this system. The ones that were accepted, a thank you letter explaining to them what happened, and on the occasions where you have crews ringing in that the SPOC then, the single point of contact then picks something out that means that they're not suitable, that flags up onto the system as well, and those crews get a letter explaining to them why it didn't meet the criteria, and then re-explains the system, so the learning process has come out of it as well.
Thank you.
Good, thank you all very much. Anthony, it's been really interesting, thank you. As always with these presentations around patients and clinical issues, my sense is we could spend the rest of the meeting talking about it. But thank you very much. I just wonder whether exceptionally, is there any quick question or two from members of the public who are here? No would be a good answer. Push you on. Good, anyway. If there's nothing further, Anthony, thank you very much indeed. That's really interesting. Thank you very much. And we'll move on, or we'll stay with item 7 for the rest of the meeting.
Yeah, thank you, Anthony. So we move on to the quality report, laid it out with a summary on pages 1 and 2 that I'll take you through, referring to a number of appendices. So at the previous board meeting, I mentioned that the CQC, who hold a quality risk profile on us, the position had worsened, and that was due to non-attendance at a meeting. We've challenged that, and just for governance purposes, you can see in Appendix 1 that they've confirmed that we were at the meetings that they didn't think we were at. Moving on to the ambulance clinical clinical quality indicators. So to remind the board, there's 8 ambulance quality indicators used nationally. 4 relate to cardiac arrest, 2 relate to stroke, and 2 relate to myocardial infarction or heart attacks. We're currently green against 4 of them in terms of our contractual targets. The position is slightly worse than last month, but just to remind the board that due to the nature of the way the clinical data comes through, this position updates, and actually we report to the board, to the Department of Health 3 months in arrears. So actually the figures you see here are liable to change as more clinical data comes through.
Yeah.
But it gives us a position about where we are now for April, and you'll see I've explained quite a lot there about stroke 60, which we talked about last time. And in Appendix 2, you'll find an in-depth study we've done over a 6-month period of our stroke 60 cases, and we've looked to see what are the reasons why we might be taking too long. We found a number of areas. One was that the coding really mattered. So when you phone up 999, whether or not you're telling us you're having a stroke, if you tell us the right thing, you're more likely to end up going down the right pathway than if you don't, which may seem logical, but it puts a whole emphasis on public education and making sure they phone for stroke symptoms. The second part we looked at was the correlations, and you'll see that in Appendix 2, around what's having most effect on us delaying stroke 60. And the strongest correlation, I guess we expected to be transport time to hospital, but it was actually about how much time we spent on scene. So we explored that a bit further and looked at an in-depth study with a workshop of frontline clinicians and control room staff to unpick that, and discovered actually that on scene has 2 elements. One is if we've got a car that's waiting for an ambulance, that extends on scene time, and secondly, that if we've sent a car and then an ambulance comes along, there's a duplication in terms of the assessment that's done of the patient, because we have to do a clinical handover from one clinician to another, as opposed to sending just an ambulance. So we found that people who get an ambulance first up had the highest chance of achieving stroke 60. As such, we've taken forward a number of actions. The first, you'll see them listed there. The 3 actions we've taken forward, amongst another, but the 3 I want to highlight to the board are: we are trialling in one county sending a double-staffed ambulance as the only resource to a patient who shows that they're suffering with stroke symptoms. So we're trying to minimise that on scene time based on the evidence we have. Secondly is we're training our HEOC staff about those processes to try and make sure we really do pick up these episodes as soon as we can. And thirdly, to try and reduce that on-scene time, we're trialling an advanced stroke life support course with some of our stroke champions to try and encourage them to spend as little time on scene as possible to get to the to the patient hospital. So they're the 3 initiatives that we're taking forward currently. The other ACQIs you'll see outlined in Appendix 3, and happy to answer questions on that. Appendix 4 outlines our complaints. In May we had 62 new complaints. To put that into context, we had 85 in April and 109 in March, so a decreasing picture. Serious incidents, we declared 1 new serious incident in the month of May, which related to a delay in getting an ambulance to scene and the patient died. We have, as you'll see in Appendix 5, closed down a significant number of serious incidents, which was one of the points concerning the board. So there is now only 2 outstanding serious incidents that require closure, and I'm happy to explain why they are if required. Infection prevention and control, you'll see comes up on the agenda later as item number 14 in terms of my annual report as the director responsible for that. But what we are seeing is good compliance with the quality of infection prevention control, and we're moving towards increasing that around hand hygiene and uniform. However, the number of audits we're doing is not the level I'd like them to be. So when we do audit, the practice is good, but not quite at the level I'd like them to be in terms of the number of audits. So the quality is good, but the number needs to increase. Last bit of news I'd like to report, and it specifically relates to the turnaround plan and also our quality account. Neil just mentioned it, feedback to staff. Fundamental in relation to the practice and making sure that it's safe is our Datix system, which is what we use for incident reporting, has had a systems upgrade, so thank you to the IM&T team for doing that. And you'll see listed here that there's some additional functionality we have, but prime among all of that stuff there is increased feedback to staff, so they can log into the system and can see what's happened to the incidents that they've raised, which is directly related to both the turnaround plan and our quality account priority around feeding back to staff and how that creates safe patient systems. So that's my summary. A number of appendices there. Happy to take questions on any of that.
John, thank you very much. There is a lot of information in this paper. and it's really interesting. Can I just concentrate on the stroke 60 just for a moment? Just remind me, when would you expect to know the outcome of the trial you're running with double-staffed ambulances?
So we've just started it in the Bedfordshire area. We're going to run it for 4 weeks. It's literally just started, so by next month I'll be able to give you the early indications around that. However, the caution is that we have to wait for the clinical data to come through. So what I will be able to give is indicative findings around the caller said it was a stroke, how long did it take us to get them to hospital, but
Right.
not all of them turn out to be strokes, and we have to wait for the clinical data. Quite often that's in paper format to come through from our
Yeah.
clinicians. So happy to give an update at each board meeting, because the pilot is now live, but like I say, we run about 2 months in arrears when it comes to clinical data,
Yeah.
just because of the processing.
Okay, and I guess, but how far ahead are you in your analysis of, if that were a positive outcome, what would it then take to roll that out more widely in terms of cost and resource? Because it feels quite resource intensive.
I'll pass it to... in terms of the HEOC education, that's part of their professional updates programme, that's already costed.
Yeah.
In terms of the advanced stroke life support, that would be additional discussions with Francesca around learning and development funds, but it's an online course. But the actual sending the ambulance, I'll pass to Neil, because that's your
Yeah,
expertise.
thanks, John. I think that the change of process is about making sure, as with everything, that we get the right resource to the patients as early as possible. And of course, with our current systems, John's point about getting the most accurate information from the caller as early as possible to indicate a stroke is really important. Everyone, I'm sure, will remember the FAST campaign of seeing the burning part of the brain in the adverts. Actually, that's probably one of the most successful public campaigns I've ever seen. And for us, what we noticed in our analysis is card 28s, which are the stroke card in the NPDS system, our triage system, dramatically improved overnight because of that campaign. So public education is really important, so that we know at that point that we can do that. So in terms of changing the process, actually, as with all pathway change, it's about managing the clinical risk to that. If this is successful, then rolling this out to the rest of the organisation is relatively simple in terms of a practical approach. It's the education and training that John's highlighted that probably takes a little bit more time to embed, but it's something that he's working through. But the practical deployment stuff's relatively easy to change.
Okay, thanks, Neil. I'm really with you in terms of public awareness too. If I take the sort of 3-hour window between event and resolution in hospital, and the stroke 60 is the middle part of that. I mean, the more time you can save in that first hour, the better it is for patients, and indeed right through the pathway. And the real importance of that profile of public awareness of, really rapid calling for help if you think you or a relative are affected.
And John can talk more eloquently than I can clinically about that, but I think that 3-hour window for us, particularly with some of our rurality and our geography around where our stroke centres are, is so important that actually it's the outcome for the patient that's the really important element of this. So the earlier we can get involved in that,
The better.
The better in all of our patch, absolutely.
Yeah, thank you. Phil.
Thank you, Chairman. It's on the same subject, and I was looking at the AMPDS category, which is about 3 pages in, and I think the non-execs were very grateful to attend the Stroke 60 Day that John mentioned with HEOC staff, dispatch staff, and clinicians. Gave us a better in-depth understanding, but it was a piece of work that was commissioned by the Quality and Risk Committee, by the non-execs, because we'd looked at the variable nature of performance. And I'm right, am I not, in saying that the pilot is only about card 28 dispatches. And what we see in here is that in some instances stroke is not necessarily misdiagnosed, but because of the way the call is taken and the information that's given, sometimes it's not coded as card 28. And so the issue around public awareness and being clearer about potential stroke means that this pilot will be more effective. And the other point that I wish to make is that as a result of that work, the clinical focus groups that we have within the Trust actually do look with a bit more rigour at these issues. And last week I attended the Essex Clinical Focus Group, and we were looking at the numbers, which, although it says they've increased on page 1, 53.2% in Essex compared with 44.5%, there was still much more of an issue around actually what do we still have to do. And in many instances it was the failure to take blood glucose, which seemed to me actually a relatively simple thing to do, but it is in order to rule out hypoglycemic attack as opposed to stroke, and so quite an important test. But the Daniel Phillips, Clinical Focus Group Manager, was about actually we need to do more to cascade this down. This is a simple test that can easily be taken, and that will bring our numbers up.
Yeah, absolutely. So you're referring there, Phil, to the care bundle, which is obviously slightly different to Stroke 60, but the care bundle, as reported this month, is 94.4. We have seen it, obviously, as a clinical director, I'll say that should get to 100%, and you're quite right in citing that the blood glucose measurement is the area we need to continue focusing with our staff on, but around the patch, by far the majority of the time that is happening, and we will continue the education to pick up those final few percent around excluding hypoglycemia as a potential cause for stroke. Yeah.
Thank you.
Margaret.
I'd like to move on to serious incidents, if I may. That's exhausted. Thank you, Chair. I think it's really pleasing to see both complaints and serious incidents reducing, and maybe we shouldn't be too surprised because they are linked, although not directly, to dispatch delays. So as we see the performance improving on dispatch, we would hope to see performance improving also on the incidents. What I just wanted to check is that whilst we haven't had many, in fact we've only had one serious incident since our last meeting, that the backlog of closing the investigations has continued to make good progress, and that soon we won't have any historic backlog. We will only be investigating the very few incidents we currently have. Could you give that assurance?
Yeah, so the table, which is slightly further on from the, shows that when I came at the end of March, there were 22 open serious incidents in the system. There are currently 5 that are open in the system. 3 of them are within the 6-week time frame that we have to do that. So there's only 2 that are beyond the 6-week time frame. Happy to explain to the board why that is. One is around quality, so I've held the report back intentionally. So instead of submitting it on time, with discussion with the commissioners, I've held it back because I wanted a further investigation to make sure we got to the root cause analysis. The second one is held due to an information management and technology failure in somebody's computer, which has just had an extension applied, and both the commissioners and the Risk Summit were happy with those 2 extensions. So there's 5 that are open. 2 of them are beyond the time frame. They are due for closure shortly. There's rationale for that. So once they're closed, there'll only be 3 that are open, and they're both all 3 are within the 6-week time frame.
I just wanted to make sure we weren't stalled just before we got there.
Yeah, absolutely. Thanks.
Thank you.
Andrew, you had a question?
Yeah, just a quick question on complaints. Good to see that the numbers are going down, particularly as I have to sign off the final letters and the final reports. John will know I occasionally have a humour bypass moment around how long it takes us to deal with some of the complaints. Is there anything we could have in future reports just about how long complaints actually take from receipt to when I sign off the final letter? Because as well as numbers, I suppose it's that quality side of it.
Absolutely. So we follow a pathway. The only thing we're measured on, if you like, is the ombudsman requirement about acknowledging a complaint within 3 days, and you'll see that in the dashboard is quite often 98-99%. However, completely support you, Andrew, that what really matters to patients, if you had to complain, is not that we've said yes, thank you for your complaint, but actually when do you get that final outcome. We do measure that time frame. More than happy to include that in future reports, and that percentage, and I know I'm going to be working with Neil's team to try and get a dashboard set up around that. So yes, absolutely, and it's something I've already requested.
Good. Okay. Are there any further questions for John? Okay, in which case we're asked just to consider and approve that report, which we're happy to do, and we'll move on to item 8 and the corporate dashboard, which Andrew, you can lead us on that.
I'll kick off on that one, Chair. Thank you very much. Yes, usual 21-page lengthy report, which I won't go through page by page, but just some highlights that I wanted to pick out. One is clearly about response times, and the question of, are we getting better or worse at responding to calls from patients? We've broken down by CCG on page 18 in this report. So you've got the May figures there, but if you actually go through the actual reports, board will see that for Red 1 calls, so our most serious calls, our performance has improved from April to May. The Red 2 calls, again, performance has improved from April to May. And the Red 19 standard, again, performance has improved from April to May. I think what we have commented on in previous boards is we shouldn't just focus on the red calls, we should also look at the green calls, because they are the vast majority of the calls that we actually receive. And I know Adrian's been working on an updated dashboard or vital signs to report to us on that. Again, on the green calls, we are hitting all of our targets for green 1, green 2, green 3 and green 4. So the contract that we signed with our commissioners, we are hitting those expectations. And the same goes for our responses to the GP urgents, so the pickup times for urgent requests for transport from our GP colleagues. So an improving picture, still lots more to be done on those. So we are hitting the national standard on Red 1, but we are just under the national standard for Red 2. And just to remind the board about national standards, Red 1, the target is 75% within 8 minutes. We're actually hitting 79.64%, so we're some way above the national standard. For Red 2s, again, the standard is 75%, and we are currently, as a trust in May, at 74.15. And for Red 19, the standard is 95% within 19 minutes. And as a trust in May, we are 94.56. But going back to page 18 at the CCG level, I think it's also worth noting those who've gone back to check, well, how are we doing in April, will see that in May, 15 of the 19 CCGs performance has improved on Red 1. For Red 2, comparing April to May, again, 15 CCGs performance has improved between those 2 months. And again, the same measure for the Red 19, 14 of the 19 CCGs, the performance has improved from April to May. So in no way complacent about how far back we've had to come from around some of our response times, but I think it's a credit to our staff and I think a credit to our partners that we are seeing improvements, Chair, in our response times. All of that's built in to the turnaround plan, all of that's built into our daily work on just making sure we've got enough resources out there on the road and that we're using those resources as effectively as possible. So that's the response time element of this report. If we then look at some of the other key issues, handover of patients at hospitals. What we see on page 3 in this report is that since the rules around contracts and financial penalties came into force in April, we have seen a significant improvement in the handover delays at hospitals. So that's a really good position to find ourselves in, because as I often say, an ambulance can only be in one place at one time, and if it's queuing at a hospital, it can't be on the road treating patients. So an improving position from arrival at hospital to handover to the hospital. Fair to say we've got a bit more work to do around then getting our crews to be clear, what we've called go green in 15. As you will see from the bar chart on page 3, the issues that we've got to face, which is the sort of reddish bars, some way to go on that. A really strong focus in our sectors, a really strong focus, I know, in Neil's team to make sure, again, this is all about getting our crews back on the road, getting them available to be able to treat patients and respond to them quickly. So an improving position overall on handover delays, but again, we are by no means complacent in the bits that we've got to do to make that better. One of the other issues that we spent quite a bit of time on as a board is sickness. Our sickness levels are continuing to go down. At one time we were quoting figures, I suppose in double figures at one part of the year. We are now down to, I think it's 6.25% as our sickness level. What we said we wanted to do was get down to 5.5% by the end of the year, so we are making good progress on reducing our sickness. Again, that's about making good use of our resources, making sure our staff are available, they're on the road, they are in our vehicles, they're in our control rooms, they're available as support staff, just making sure we can focus our efforts on that. And I suppose to complete the picture, without replicating what John's just done in his quality report, complaints are down and serious incidents are down. So I suppose my overview would be still huge amounts of work to be done. We know we come from a long way back on some of this, but response times improving, handover delays improving, sickness going down, complaints going down, serious incidents going down. I think some signs, Chair, of an improving picture in this trust.
Very good, thank you. Andrew, I'm sure colleagues will have questions. I guess the question from me straight off is, do we know why performance is improving, and can we please do more of it? I mean, do we know why performance... I mean, that's the thing in my mind straight away. Do we know why it's improving?
Yeah, absolutely, Chair. And I think in relation to your points earlier about absolutely understanding the assumptions that fit within all operational models and in everything we do as an organisation, there's three key factors that have influenced our performance improvement in the first April and May of this year. Those are an improved resource level on the road, so we've increased our number of ambulance hours, as we said we would in the turnaround plan. That's also increased our number of qualified clinicians, so that's more of our own staff staffing ambulances out on the road as well. So we've seen a significant improvement in that, up to 98% of our ambulances covered with our own staff. So that's a substantial step change from where we were. As Andrew's already mentioned, hospital turnarounds improved ahead of our assumptions and our modelling for this part of the year, which is a positive step. And also for the first 2 months of the year, while activity is slightly up on last year's outturn, it was below what we had factored into the model for Q1. So absolutely, the three factors are activity is down slightly, hospital turnarounds are improving, and our cover of ambulances and resources out on the road has increased.
Okay, and is that sustainable?
We've sustained it so far into the first 2 months. There's a continuing challenge, as always, of balancing the quality, safety, money aspects of our service, as you mentioned rightly earlier, Chair. I think one of the things I would do is draw the board also to page 19, if I may, which looks at PDRs, because it's not, and I think John mentioned this in an earlier point, it's important that we focus on more than just 3 red response time standards. While they're clearly important and there are our national standards to deliver, the green patients, but also things like the education and health of our staff is equally important. On page 19, there is an update. Our PDRs for emergency services shown about 4%. That's unfortunately an admin error in this report, which is being addressed. I can update the board. We've done over 1,400 PDRs and staff appraisals. Apologies, staff appraisals at this part of the year have already been done in the first 2.5 months. Really to sit down with our staff and talk about this year, where the organisation is, the turnaround plan, their future, their development, how they fit into the overall plan, what do they contribute to the rebuilding and the turning around of this organisation. And I think that's a really positive element to add to that. So in terms of your sustainability question, Chair, then it is sustainable, but there's a lot of work to be done to make sure that we balance those 3 key priorities.
Okay, lovely, thank you.
I suppose cutting to the chase, we replied to the Care Quality Commission to say that we would be completely back on track. We would be achieving good performance by November, 1st of November. We're seeing improvement now. I suppose I'm just looking for assurance that particularly execs are confident that we will be providing the best service we can and to the targets that we're set by the people that pay us the money, the CCG, by the 1st of November, because that's the key thing. That's quite a hard, fixed point that we can be aiming at.
Certainly in relation to that question, Margaret, the trajectory, the performance trajectory is a monthly one that's evidenced and that was linked to the response we gave to the CQC. We're currently on or ahead of that trajectory for all of our key standards, and we will be maintaining that, is my belief, for the rest of this quarter. There's still work to be done in terms of working with the commissioners around the level of resources out there, the support required on a transitional basis to enable us to achieve the resource levels and the balance to continue to maintain the number of transportable resource hours in particular to deliver that trajectory. But yes, we're currently on track against that.
Good, let's keep there then.
Okay. Phil, last question and then I'm going to move us on.
And it's a similar question to that from the chairman, but this is around handover to Claire. Do we know why there are differences? Are they related to the particular geography of each of the hospitals, or some of the processes and procedures? But Margaret and I, of course, are aware that having been recently to Southend Hospital, that A&E is being reconfigured, and it takes a long time now to get from the ambulance into and then out of A&E. And so are some of these structural, or some of them perhaps transient, and is there a level of confidence that the handover to clear times will rise across the year?
Thanks, Phil. In relation to that, every general manager in their area has an improvement trajectory looking at their handover to clear turnaround times. There are a multitude of factors, all of the ones you've really just listed, from everything from the processes at local units to some of the physical geography of local units, and the risk of spiralling into a data quality discussion. What they're focusing on locally is making sure that staff are aware of the importance. Andrew referred earlier to something called Go Green in 15, which is a pilot that's been rolled out really across the whole of the region, which reinforces to staff the importance of the turnaround, the importance of being available for the next patient. We've got, as part of our listening to action work, one of our pioneer teams will be looking at processes at handover. We've got something that we're also looking at called the pit stop project, which looks at how we treat our crews like that as a pit stop, so that their ambulances get cleaned, wiped down, the IPC's compliant, actually our crews get refreshments, and they're easily available for the next call. So, particularly some of our staff that are going from job to job, as that happens in areas, it's about making sure that their welfare is looked after as they arrive at hospital as well, but we do it within a timely fashion. So there's a number of initiatives in place across the region to address this, and there's some very specific key measurables as well for each of the general managers in terms of reviewing their long delays for handover to clear, how they're doing those, and we're also working with the commissioners on the system and technology to ensure a more accurate handover time before.
Thanks, Phil. Thanks, Neil. Okay, good. I'm going to move us on, but let me just say it's really important, really good to see some positive signs. That's fantastic, but we need to be sure, Neil, these are incremental, not random. They are genuinely incremental as a consequence of actions we are taking, and of course that they're sustainable. Which moves me on, I think, quite neatly, Stephen, into, if there's nothing further on item 8, into the finance report. Can we move to that?
Yes,
Thank you,
Chair. Okay, you'll note the contents of my report. I don't intend to go through it in detail, but would like to kind of give you a summary overview. At the end of month 2, so as at the end of May, the Trust reported a deficit of 1.995 million against the planned surplus in our budget of 255,000. Therefore, at the end of month 2, our variance to budget was 2.2 million. At the end of April, we were at 1.3 million as a comparison. The 2.2 million is made up of 3 main areas of variance. The first is related to income, where we are 850,000 below budget, and this is due to 2 main areas. One due to performance targets and activity targets. Expenditure, we are 452,000 on pay underspent due to a number of vacancies that we have within the organisation currently. but we are overspent on non-pay around PAS expenditure of around 1.8 million. Those three areas conclude the variances of the 2.25 million that we currently have. Over the page, we have also identified, as you would with any organisation, a number of risks in our plan. These don't necessarily mean that we are going to not deliver our overall numbers. At the end of the year, we are still expecting to deliver a surplus of 3.1 million. However, as you would expect, we have identified a number of risks in our plan which we are working on mitigating at the moment. On page 3, we have identified some of those risks. One of the key risks is around over expenditure on PAS, on private ambulance service, and other areas around making sure that we deliver on performance for penalties and activity, the kind of key areas and where we've identified risk. And we have got a particular working group working on those key areas at the moment to ensure that we mitigate those so that we still deliver our forecast surplus of 3.1 million at the end of the year. Over the page on 14, we show some more detail around those particular risks and our opportunities. As you would expect, there are opportunities in our plan as well to deliver further income and further contributions into the organisation. And in relation to our cost improvement plans, we are slightly behind on our cost improvement plans, but intend to bring those back into balance by the end of the year. And that in relation to the P&L. In terms of the balance sheet, on page 10, we have total assets employed at the end of May of 48.966 million, compared to actually March of 50.96 million, the difference being the deficit to our plan in terms of profit and loss for the month of May. And we have cash of 17.46 million at the end of May. That concludes the finance report as at the end of May.
Stephen, thank you very much. A second triumvirate that the board very much has in mind is that triumvirate of performance, quality and money. And we need to find the right balance amongst those three factors. So in delivering performance, we need to make sure it's sustainable. In making sure we achieve financial balance, we must make sure we don't do that at the expense of delivering performance. That's the challenge that we have to find the answers to. And whilst it is certainly the case that there is a deficit at month 2 and a continuing run rate deficit, what I find really encouraging, Stephen, is that you and the executive team are on that case. Yes. It's not a matter of saying, oh, it'll all be right by month 3 or it'll all be coming good by month 6. Not a bit of it. We need to make sure we stay hard focused on that aspect of the organisation's performance too. Yeah, thank you very much. Any questions for Stephen at this point? Can I just one quick question for just to make sure I've understood things properly, Stephen?
Yes.
In your report, you say after taking account of other key risks and opportunities which could impact on the position, the risk-adjusted forecast indicates a potential net risk in excess of 12 million for the trust. That's before mitigating actions. So when you say net risk, you don't mean after mitigating actions.
That's if everything went wrong and we didn't have any mitigating factors,
right.
And we made no actions to deliver any of the changes, then there would potentially be a downside of 12 million.
That's fine. I've just had a momentary ambiguity about those words there as to that was before mitigating actions. Comments or questions for Stephen at this point? Andrew?
Probably more a comment than a question. I think the really important part, and I think this is one of your statements, Chair, that hope is not a strategy. That I've joined enough organisations and done enough financial turnarounds to know that if you don't get onto this early, it can run away with you, and you can end up at the year end in a position you never wanted to be. So, I mean, Stephen's been with us 3-4 weeks now. I think he's firmly got his hands on this. As an executive team, we have our arms very firmly around this one. Our very clear assurance to the rest of the board is we will come in on our financial plan, but it's right that we flag up that if we do nothing, it comes in as 12 million. That's not going to be an outcome that's going to be acceptable to any of us. And therefore, as we come on to the next paper and future reports to this board, it will be about, okay, then what are those specific actions that are going to mitigate that 12 million risk such that you come in with the 3 million? And that's what we are working through.
Good, thank you. Anything further at this stage for Stephen? No. Right, I think we stay with you, Stephen, for
Okay, thank you very much.
9B. Thank you.
So item 9B, again, just to reiterate, we do remain on track to deliver our surplus of 3.1 million. But as all good organisations, as we've said, will look at its risks in delivering that, and we certainly have spent a lot of time as an executive management team and senior management teams below that in really understanding the risks we face over the next 10 months to ensure that we have mitigating actions for those. Appendix A, and I don't intend to go through them, identifies those risks, but the key areas, as I've previously stated, are around achieving performance, around management of private ambulance expenditure, and ensuring that, particularly things like 111, that we deliver against the contract, and you can look through in Appendix A to see the individual areas. The more important thing for us to talk about is how we then mitigate those and how we're going to make sure that we still deliver our plans. And we have 3 specific actions that we've taken as an executive management team to review. First one is around private ambulance service. As we've talked about, we've spent probably 2 million at month 2 over budget in terms of where we anticipated, although some of that is offset by the fact that we have less staff at the moment and we have a number of vacancies. Given all of that, we want to make sure that we are using it appropriately and spending it appropriately, and a working group of a number of operational areas within the group are sitting down and reviewing that at the moment, and we are coming up with an action plan in terms of how we contain, review and manage the expenditure on private ambulance to make sure that in line with our performance we are still achieving performance, but we are managing that private ambulance to the most effective route, and that encompasses all areas of the organisation to help us do that. On top of that, as you would expect, we are looking at all the budgets across the organisation, and our staff budget makes up around 160 million of that. And what we need to make sure is that we are maximising the resources we have available to ourselves, minimising any duplication, and understanding fully the structures that we have in place and why we have them in place, and can we justify the expenditure. So we are currently reviewing those, and over the forthcoming weeks we will come back with some outcomes from that in the sense of how we spend that money and what potential savings or changes, how we can reinvest more into the front line from that to make sure that we identify that we are spending things appropriately and being effective in the management of our cost base. In addition to that, we also spend around £60 million on non-pay, and as you can imagine, one of my first questions when I arrived at the Trust is, well, what do we spend that on? What are the top 20 items? Are we procuring those effectively? Are we spending those effectively? And is there any other way in which we can manage those and look at those? So there's also a working group reporting back to the executive management team that are looking effectively at that non-pay spend to see how we can reduce that and make savings again to ensure that we safeguard and have a safe landing with our financial plan, but also invest more into the front line. Thank you.
Stephen, thank you very much. Comments or questions for Stephen? No? Okay. Phil, sorry?
Yeah, just briefly, Chairman, what was interesting in Appendix A is that what we have done is actually sort of analyse the risks and assign, I hope, a realistic probability of achievement and so on, because identifying risks and identifying mitigation, actually, unless you have the confidence that those mitigating factors are going to work, of course, it
doesn't help.
It certainly doesn't. And the fact that by seeking to assign, say, a RAG rating to these, I think is helpful, because it gives you a little more confidence that you know what you would expect. You need to do a little bit more, perhaps, to deal with
Phil,
the
thank you for that.
adverse.
Absolutely right. I would go perhaps even a step further. And for me, this is not quite there yet. I think it's still work in progress. And what I would want to see, and it really builds on your point, at the end of the day, is my metaphorical one side of A4, which says, here are the actions, this action, these people, this time scale with this outcome, so with these assumptions, so we as a board can be assured what what actions will be taken in this financial year to achieve financial balance in this financial year, and we can then be assured what those actions are, what the assumptions are being made underpinning those actions, what the level of risk is, and we can be assured that that is then achievable. Stephen, sorry, I interrupted.
Yeah. The other point to make is that in identifying all these risks, we engaged with a number of people throughout the organisation to make this, to review this, and really have embedded that into the organisation so that managers, senior managers and the executive management team fully understand that. There's the executive management team lead on it, but there are also leads within the sectors, so everybody in the organisation is really owning and understanding what these risks are.
When are we going to see the outcomes of all this, when are we going to see it start to come through?
Yeah, in terms of all the plans, they will certainly be ready for the next board meeting, and we need to be actioning them before then. We've got 8 to 9 months of savings to achieve, so we need to be on with them now.
So when are we going to start to see these figures moving in the right direction?
I would say give it another month from now.
So so when are we going to see at this board? So does that mean?
So month 4, I would say we'd start to see the results.
So by the month 5 board,
yes,
we should be able to see these figures moving in the right direction.
Yeah.
What calendar month is that? Somebody remind me. So, okay, so we don't have a board meeting in August. So by the September board meeting, we should see at least 2 months' worth of improvement in figures. Yeah?
Yeah, absolutely.
Okay, that's what we'll be looking for. Okay, thank you very much. Anything else from colleagues? Good. Stephen, thank you very much. Let's move on to item 10. I'm going to try and pick up the pace a little bit because I'm conscious that time is moving on. Yeah. Item 10.
Thank you, Chair. Members will be aware that we've had a self-certification to what was the Strategic Health Authority every month. Since they ceased to exist on the 1st of April, we now have a Trust Development Authority self-certification, which is attached in the file. This is the first time members will have seen this report. It is very much a board assurance report. So these are the items that the board should be assured upon in order to say yes or no, obviously, for this report. It is pretty self-explanatory. The guidance to this form runs to 200 pages, so I wouldn't... I thought it was probably not best.
When are we moving to iPads?
Well, unaccustomed as I am to reading big documents, I did have to read all 200 pages, so I knew what to put in each one of the form.
Okay.
But this form is about almost is the combination of everything we talk about at the board in some respects. How does the board, and especially the non-executives, get assurance around all of
the
these
different
issues?
risks? Yeah. Okay. Right. So what do we need to do with this? Just to note it, basically.
You have to authorise me to send it to the TDA
in due course.
by the end of the month. Yeah.
Okay. As a statement of the position as of now.
Yeah.
Okay. Colleagues content to do that? Yeah. Good. Thank you very much. Anything else on item 10, Adrian?
No.
Thank you. Item 11, Andrew, I think it's just a verbal update.
No papers attached for item 11. As the board will know, we have now received the Independent Governance Review report. So this was a review requested by the Trust Development Authority, the TDA, a review that Anthony Marsh, my opposite number in the West Midlands, carried out in March and April. That was published on the 11th of June. All board members have received a full copy of that report, and there's been considerable media coverage of the content of that. It contains 25 recommendations. Many of those are already picked up in our own turnaround plan that we published in April, and which are actions on which are already underway. But what we are required to do as a board, and something we are doing as an organisation, is to consider the governance review and produce a detailed action plan in response to that review. But what we've been asked to do is draw on not just the governance review, but our own turnaround plan, which has got 89 actions in it, and the Care Quality Commission report that was published a few months back, use all of those and any other reports that we've got as the source documents for a single action plan for this organisation for 2013-14. Work is underway on that. We've been asked to send a draft, or the final draft of that, to the Trust Development Authority by the 5th of July. So I think that's a week this Friday, I think, by my calculation. They will obviously then review that plan. I'm sure they will have some comments on. That's the normal form. It will get refined, and then we will end up with the final action plan, which will come back here as soon as we can possibly do that. We have agreed to utilise Anthony Marsh's further input, probably for a couple of days a week or so at the moment, just to help us both in the preparation of the action plan, but also any additional support he's able to offer us as we look at improving both the governance of the organisation but also our operational improvements. And the Trust Development Authority have made it very clear that they will both provide support to us because they want to make our success more likely through that support, as well as monitoring our progress against the action plan that we produce. And that they have made very clear that will also include progress against our own turnaround plan. So it's a bit of shuffling a pack of cards almost, Chair. All of the documents we've already got into a single unifying action plan that addresses all of the things that actually we know what we need to be doing. The governance review was not a surprise to us. The content was exactly as we anticipated, but rightly critical nonetheless. And as you will know, Chair, work is underway to produce that unifying action plan by the 5th of July.
Good, thank you. I need just to make one point here very clear. And we've heard this morning about improvements in operational performance. We've heard this morning, Stephen, about challenges and actions that are being prepared and will be implemented to deal with that. We've also, Andrew, you've summarised very, very well the turnaround plan. There'll be a response to the governance review. There's the CQC input. We really do need to be sure that all of that gets brought together in a single plan. I don't want there to be something out here which is the response to the Trust Development Authority, to the governance review, and then that's going on, where there's and something else over here, Stephen, which is the response to meeting the financial challenge. It's all got to come together in one single integrated series of actions that will deliver all of that. It's not one thing separate to another. Okay, comments or questions for Andrew on that? That was just a verbal update on the governance review. Yeah.
I strongly endorse what you've just said there, Chair. I suppose it's about trying to boil it down into what are those top level, I've called them sort of big ticket items, things that this board needs to focus on that will make the most difference to the organisation that we are charged with running. So that there will be some of the more minor points in the turnaround plan that probably won't feature in that overarching action plan. They will just get done. But absolutely, there will be one single unifying action plan for this organisation that will pick up all of those big ticket items like the board, financially viable, stakeholder engagement, a whole series of what I would call big ticket items. They'll list the actions, they'll say who's responsible, who's going to do what by when, and as a board, in public, in a proper, transparent way, we will show each month how we do against that action plan.
Okay, good. Thank you very much. Anything else for Andrew at this point? Okay, let's move on then. I think it's really a continuation, isn't it, in item 12, with a progress report on the turnaround plan.
Yeah, I'll touch on this quickly, but Neil and Mark, who's our programme director, who's in the audience, might want to comment on this. Hopefully a self-explanatory report on progress against the turnaround plan. So please take everything I said a moment ago into account in relating to this. What we have also done, just for those who read both the governance review and our own turnaround plan, is at Appendix B or Annex B, we've just done that read across from his 25 recommendations in the governance review, and here is the cross-reference to all of the points in our pre-existing turnaround plans. I think that's an important point that will hopefully show that when we produce this unifying action plan, there will be a lot of commonality and read across from documents that we've already got on the go. Other than that, Chair, hopefully this is a self-explanatory update on both where we are with the 89 actions, the emerging sort of big ticket items that we are starting to focus on, and again there'll be further iterations of that over the coming week or so as we produce the final plan. Our continuing engagement with all of our partners, either internal or external, to make this a success, and just the governance arrangements that underpin the delivery of this turnaround plan and what will then be the integrated action plan, or whatever we call it. So hopefully it stands as written, Chair.
Okay, thank you very much. Mark, is there anything you want to add or to comment on?
There's not too much to add to what I provided there, I think. The next stage is, or the piece that I'm working on at the moment, is to consolidate what is quite a lot of text into a schematic representation, which will form part of our reply to the TDA. And I think what would be useful, perhaps, would just to get a little bit of feedback from the board, particularly with regard to those large chunks of big ticket items that the Chief Executive referred to, that people feel that they are moving in the right direction, and that those are the sort of things that we should be bracketing together, because in order to capture the wide range of actions, there's a requirement to put them into some sort of bracket, some sort of big ticket items, to make it a manageable task.
Yeah, absolutely. Thank you. Comments or questions? Phil?
Chairman, thank you. It's very useful in capturing these and trying to put it into a single document, and I hope that so the bits that we were talking about will be added. What I'd found missing, and it might well be because this is in essence a high-level document, that we have the turnaround plans, actions, we have the lead owner, we have the timelines, and I hope what's sitting underneath that are what impact each of these will have in terms of whether it's performance, improvement in clinical quality and so on, in order to give some sort of priority to each of the items. And it's getting some of the quantifiables in place, so that when we look at this, we can say, well, yes, these are clearly I suppose the more big ticket items, if you want that all inequality, and so that's where your focus would be. And in the same way as when I used to police a finance recovery plan, we would map, is it still on track? If it's not, what are we going to do about it, and so on. And I think this is useful, and clearly it's still work in progress, but I'm assuming that underneath this will lie that sort of detail.
And Phil, again, I think, in a sense, more than an assumption, it must be there, it must be explicit, and eventually in the integrated plan, which comes forward quickly now, needs to have that information. So you've got out, as well as your actions and who's going to do it in the timeline, what's the outcome, and over what timescale, so then as a board we can be assured that things are happening in the way that we're expecting them to happen.
The next stage for me would be to have those business critical, big ticket, whatever you want to call them, items expressed in such a way that everybody from a first responder, even a fundraiser or supporter, member of the public and ourselves can all understand. And also within that, as we've said, not lose some of the detail, but actually be assured that some of the detail can be safely delegated to the relevant parts of the organisation and individuals, so that the board can put its effort into those things that might not move on without a bit of a shove and a poke and a bit of interest from the board. So it's a bit sort of segmented, but you've got to get to those big ticket items and understanding first, I think.
Okay, good, thank you, agree with that. Okay, we're asked to consider and approve progress so far. Are colleagues content to do that? Yeah. Phil, you're okay with, thanks for your comments there. Good, Mark, thank you very much. Does that give you a sufficient steer? Yeah?
Yeah, we should get it replaced by next Friday.
Okay, thank you. Right, let's move on. Item 13.
Okay, good afternoon everybody. My name's Glenn Young, I'm the Listening to Action lead, and this presentation will complement the paper in your bundle. This is our poster, this is my call to arms for the organisation, and it shows our journey from where we are going through and all the different activities the organisation does. So I'm quite proud of this, and we've been pushing this around the whole organisation as my call to arms. So I'll just move on again. I think it's so the objectives of LIA. So the goals of LIA is to let staff lead and change the way we work, get them infused and energise staff, improve morale, and when we hear good stories come from staff, we get to share them. And I've got 2 examples of that, and that hopefully those good stories will inspire others to come forward with their ideas how we can change the organisation. So we're in phase 3. Phase 3 is the action part of listening to action. And what we've done from our big conversations is that we've mapped everything into the turnaround plan. So this slide here, I won't go into too much detail, but what I want to do is give you a couple of examples of ideas what have come from staff. The first one I want to talk about is a clinician from Essex who came up with an idea about us piloting using biodiesel. So he emailed me with this idea, I met him, and since then we connected, using us as we connected him to the right people within the organisation to talk about his idea. So what's happened over the last few weeks, he's met with my colleagues in the fleet department, and they're actually going to trial with driver training school the using biodiesel with one of their vehicles. Now there was obviously some benefits of using biodiesel. It reduces the trust carbon footprint and it's cheaper. So that's one example, and the individual that came up with the idea has been part of that process the whole way through. So it's not his idea and someone else has run away with it. He's been part of it, he's gone to the meetings, he's been driving it. And listening to action enabled that. So it's about us connecting the right people with the right people in the organisation. The other example, right at the beginning of listening to action, we was going around doing lots of station meetings, talking to staff about the principles of LIA. And we came across a particular station, again, in Essex, where we had my colleagues, the vehicle cleaning operatives, where they're working, their estate needed improving, I should say. So, obviously, we fed that back. We have a sponsor group which meets fortnightly, where Andrew chairs, and that was raised at that. Now, since then, the estate department's got involved, again, connecting the right people, and they've just agreed to improve their estate at that station, and I believe on one other. And that's a good example of direct feedback from staff to people in LIA coming out with good results. And again, we need to share those examples with the rest of the organisation so that we encourage other people to come along with their ideas. This next slide is one of the big things that come out of our big conversations a few months ago was our leaders. So what we've done, we've pulled together what we call 7 behavioural LIA leaders principles or traits, and what we're doing every time we go around, we meet the management teams, we're enforcing this with them that this is what we want to see. So, and I want to point out number 6, recognise if we do the same old approach, we'll get the same old results. So unless we do things differently, we're never going to change. Quite compelling, that one. The next slide is about, obviously, as you can see, it's about the quality. So LIA is about embedding these principles in the organisation. It promotes it, and it's ultimately to improve a better service for our patients and a great place to work for our staff. Last slide. Again, LIA outcomes. LIA is about making the right changes in this organisation. It's in empowering our staff, our managers, to make the changes that we need to see. And most importantly, really, it's to make this organisation deliver a better service to our patients and, again, make this a great place to work for our staff. Thank you.
Fundamentally, staff morale and performance of staff, at the end of the day, everything we do depends on staff. people. It all depends on people, having people who are well motivated, well trained, well supported, and given the capacity and the ability to deliver. That's what this is all about fundamentally. Any comments or questions for Glenn? I think it's a really interesting, motivating, energising programme, and it's good to see. Comments or questions for Glenn? Andrew?
I mean, this was something I kicked off, I think, on day one, or probably even before day one in this organisation. I sense when I go out and about across our patch, people are starting to see that we're serious about this, that it's not an initiative, it's not some passing fad that we're going to have. You know, this is going to be how we do our business around here now. So point number 6 that Glenn pointed on there, you know, if we do it the same old way, we'll get the same old stuff. And it's quite clear we don't want the same old stuff around here. We want a better engaged workforce who are both our ambassadors but also our change agents, the people who make change happen. And they don't need to ask for consent, they don't need to write a business case all the time, they don't need to go up through several layers, they need appropriate governance, and it's our job as a board chair to make sure there is that appropriate governance and assurance. But there are so many good ideas out there, so many good members of staff who just want to get on with this and just want to be freed up from some of the old ways that we used to do things, that we're starting to see that percolate through already. When we go out and see other trusts who've been through this, and Glenn was out, I think, in Croydon last week, a troubled trust that implemented listening into action and is seeing real benefits from its workforce of both morale, but more importantly, the improvements to patients. They are starting to come through big time. So I've nailed my colours very firmly to this one. It will work in this organisation. It will change the way people feel. And I think you're absolutely right, Chair. We're in a contact sport. We employ people to look after people, and if we don't focus enough energy on the people side of the organisation, all hope will undoubtedly be lost. But we're avoiding that, so it is going to be an improving setup.
Very good. Thank you. Glenn, thank you very much. We're asked just to receive that report, and that's excellent. Thank you very much. And I'll move us on to item 14, which is the Infection Prevention and Control Annual Report. John, is this you?
Yeah, this is me. Here, end of the financial year, so in my role as Director responsible for Infection Prevention Control, you can see the highlights outlined. A busy year last year. Quite a lot of infection prevention control is about action, but also ensuring that those actions have been undertaken. So around auditing, we had some operational pressures last year. However, a number of extra parts of the organisation stepped up, and I want to put on record the thanks to the Trust User Group who stepped in and did infection prevention control audits, and certainly just this last week we've trained the new shadow governors in the ability to do that as well. So in terms of highlight, so you can see here the vehicle cleaning operatives, which Glenn's just mentioned in his LIA presentation. We've had significant work done on our estates, so they are in better shape than they've ever been before. The champion scheme has continued, as has our professional update for staff around infection prevention control. So just to clarify, when the CQC came in January for their unannounced inspection, this was one of the areas they looked at, and they commented positively on that, and we are compliant with CQC regulation around infection prevention control. Moving forward to this coming year, 2013-14, we intend to start focusing more on uniform compliance and hand hygiene compliance. Continue to do our audits, more training for our staff in being able to do the whole range of clinical things, but specifically around infection prevention control. There's 3 specific areas there that you'll see that we need to pick up. One is around aseptic should say touch, not torch technique. Spelling error.
That'll be effective.
Yeah, non-torch techniques. This would be a good idea. So this is around when we put needles into people, being able to do that in the most effective way. European Sharps Directive, which is the European Union, it has to be applied across the whole of the EU, so that includes us. As part of waste streams, we're aware that we put significant amounts of our waste currently into yellow bags when they could go into orange bags, without getting technical, but that's good for quality, but significantly good for money saving and for sustainability of the planet. So there's some of the things we're going to take forward this coming year. Happy to answer any questions on the end of the year for infection prevention and control.
John, thank you very much. It's a critical part of governance, I think, infection control. And certainly having wrestled in the past over issues with Clostridium, over things like multi-drug resistant tubercle, for instance, resurgent syphilis, MRSA, the obvious ones. Just one question in my mind, really. What sort of focus is there on what's next? In other words, sort of a forward look which says, okay, we're doing all these things to address the infection risks that we know about, but so often in the past these infection risks have materialized unexpectedly. So is there part of it that says, okay, well, what next? What do we not know about? What's the next thing that we should be looking out for on the horizon?
Yeah, so I guess there's two parts to infection prevention control. The first part is very much around doing what we know is good for safe practice, and you'll notice one of the actions this year is to continue review the safe practice guidelines, because the evidence base around how you should wash your hands, what your uniform should look like, so bare below the elbows, that changes. So ensuring that we're doing what we know within the evidence. I guess the other part for us as an organisation is our clinical practice guidelines, because as our clinicians increase, we've certainly got a primary care contract. Things like antibiotic usage, we're continually reviewing, and we have to do that in partnership with our colleagues, because us doing it on our own, as you'll know from your microbiology background, actually won't work. We need to do that across the board. So we work very closely with our colleagues who are providing that primary care function about the bit that we do, and we publish things like our formulary on our website so that everybody can see which drugs we're using, so to try and pick up especially the resistant things like MRSA, the resistant drugs. So I guess there is horizon scanning. We have a person employed in the trust permanently who's got a master's qualification in infection prevention control, so that's the part of their role is horizon scanning. So yes, we do it.
It's just that sense of thinking, as well as doing everything that we know about, and that's right and proper, just trying to be at the leading edge of what might happen next, yeah? Margaret, yeah?
I mean, one of those leading edge things that we may wish to consider for the future, not the immediate actions, is having more antibacterial, antiviral environments through the materials technologies available.
Yeah.
They've really certainly come on in the last 2 years, 18 months, 2 years.
Absolutely. Neil?
Chair, if I may, I just think I want to add on to John's point about doing the basics and making sure we continue to focus on that, as well as horizon scanning, and just remind the board probably that our biggest resilience risk remains pandemic influenza. And actually with things like our control rooms, maintaining infection prevention control in there, all of our staff being absolutely aware of the importance of maintaining that is really critical for the organisation and for the nation in terms of keeping things like pandemic influenza at bay. But it's certainly something worth being aware of in terms of horizon scanning.
Yeah, I certainly get my flu shots. I hope all the rest of us do too, because it's one of these seasons it's going to happen. Yeah.
We do, and it's probably worth noting, new to the board, that we had our highest uptake this last year of our staff taking on flu vaccine. I'm sure Francesca will be pushing it even harder this coming year. So we've seen an increase in our staff uptake for flu vaccine.
John, thank you very much indeed. I think we're asked as a board to just to consider and approve the recommendation, which is presumably a recommendation to accept this report, is it?
Yeah, so it's been to
intent to do that. Very good, thank you very much. Okay, good, thank you. Let's move on then to item 15, and I'm sorry that we're 10 minutes or so behind time here, but this part of the meeting then moves to the open forum for Bedfordshire. And as colleagues will recall, the purpose of these open forum elements to the board meeting is to provide the board with an opportunity to ensure that we hear at first hand what the local issues are impacting on the service, and what more we can be doing, should be doing, need to know about in order to get things right. And the strapline, getting it right, is indeed intended to highlight that. And I think that's a really important opportunity, both for the board to ensure that we engage with those local issues, but also for colleagues here today, it's your opportunity directly to get at us in terms of making sure that you know, that we know what it is that matters to you, and have those things in the forefront of our minds. So it's an invitation, really, please, to all and any of you who would like to take this opportunity to raise issues with us. We'd be really, really pleased to hear from you. Could I just ask you, please, to just say who you are and where you're from, sort of REM style. This is who I am and this is what we do, just so that we know who you are. But otherwise, very pleased to hear from all and any of you on local issues, because it's really important that we do everything we can to get it right. Over to you. Who's going to lead us off? Pam.
I'm Pam Morris. I'm the Trust User Group member and the Shadow Governor for Hertfordshire. And thank you, Chair, for letting me speak. I wanted to ask Neil, please, this pit stop scheme, Neil, I think is going to be very good and it sounds very, very good. How many hospitals are you going to do the procedure at?
Thanks, Pam. Ideally, I'd like to do it at every hospital for all of our staff. We're actually trialling something locally in Hertfordshire at the moment at Watford. So local general manager with their crews are trialling something there whereby crews have access and availability to refreshments when they arrive. We have a local vehicle cleaning operative who used to be based at the ambulance station. We're now basing them at the A&E department. You know, the logic is, as it says on the tin, really. You know, Lewis Hamilton doesn't refuel his own car in the middle of a race, does he? So actually, for our crews, it's about supporting them, making sure that they are available for the next job as quickly as possible. So somebody that can help clean the vehicle, and if the trial's successful in Watford, we're looking at slightly different trials around the patch depending on different areas, but the logic remains the same, and ideally we'd like to roll it out across the whole patch.
Thank you. Is that a pilot though? Or, yeah. So when we do the audit of Watford Hospital during next month through August and September, we're doing 7 days, 12-hour shifts, and we should come across these people in at Watford.
You should, absolutely. And there should be access to a cup of tea for you, Pam, as well.
Thank you. Thank you, Chair.
Yeah, could I ask also on that one, hospitals like Peterborough, which are difficult, will the same procedure happen there as well?
Yeah, absolutely. What we're really trying to do is continue to drive that local ownership for the local management teams and the local staff, and it was the ideas of the staff around how each specific area develops their own concept, really, and I'm sure some will change and differ, and they've got lots of good ideas that are coming up in those patches as well to try and, but it's the same theme and concept and idea across the whole patch.
Thank you.
Peter Blackman for the local health watches throughout east of England. A number of points, if I may, I'll rattle through. I'd like to endorse the congratulations to Roland Chesney that were expressed earlier, and also record our thanks to Caroline Bales for the work that she's done during the time that she's been a non-executive director. As an aside, I think I might have coined a phrase earlier, at these meetings I see a dog but no donkeys. Moving on, when we're talking about handover from RRVs to ambulance crews, a point I've made previously, but probably not everyone here has heard it before. From a patient point of view, we want continuity and minimisation of handover. So if you send an RRV with a paramedic, from a patient point of view, we want that paramedic to stay with the patient, and someone from the crew, if they're going to transport, turns over to drive the car. And you only hand over if you need a superior medical, clinical, so a superior qualified, capable paramedic for a clinical need. So from a patient point of view, that's what we'd like to see. I understand the challenges with that, but if you're going to send RRVs rather than ambulances, that is the price that you pay, because the patients don't want to keep telling the same story over and over again, albeit we know that they'll have to when they get to hospital. What did I say was number 4? Oh yes. Absolutely agree the unified action plans required. I'm on record as having commented that I was very encouraged by the Marsh review, because it didn't seem to me that it picked up very much that we didn't know already, and just consolidation of everything into one plan obviously is required, and I hope there will be patient involvement, patient and user involvement in that development, and certainly would like to thank the Trust for its involvement of us in things over recent months. I'd like to record again our concern about the fragmentation that may result from sectorial approaches, individual commissioning by CCGs, and also the fragmentation of the operational management around the trust, and the opportunity that gives for postcode lottery, different practices and policies, and also for the cross-boundary issues of needing to keep resources in one place to meet local targets. I would ask another question, which I think might be something that could be useful to be done now, and as has been mentioned before. I do think it would be useful for the Trust to actually look at how many jobs are being done by paramedics, which actually could be done by, quote, civilians, close quotes, and to see where there is perhaps some opportunity for rationalisation. And as people will know, I've often banged on about that when it comes to community first responders, because the recruitment, development, data processing, etc., that's volunteer development, which is a specialism within the voluntary sector, where obviously you need training on a medical side, etc. So perhaps you could have a trainer who is also responsible for the clinical policy, but you have a community development worker who's helping you to build up the local responder groups. And perhaps this is the time, I know it's not been a first order thing, but that there are concerns about the arrangements for the management and operations of community first responders, which naturally has not been top priority for you, but with 2,000 volunteers out there, there's a growing degree of no lack of enthusiasm. They're still out there and they're pulling in, and I could highlight how much we're contributing to you meeting your targets, and again ask for a commensurate budget to match that. So thanks for the smile, Neil. It's about 5%, isn't it? Anyway, we'll move on swiftly from that and leave you to consider. But there is a need for something to keep these people motivated, but also for us to build up the groups and the capacity, because this is a key aspect of the political pressure that you're under about rural response times and that sort of thing. And actually, this is something that I was employing people to do when I was chief executive of a national voluntary organisation in the late 1980s. So it's a specialism that's been around in NCVO and the voluntary sector. And it comes back to the overall bit about having the management skills, having the communication skills, having the relevant skills, and not just, I'm not saying that everybody does, but throughout the NHS, you have clinical competencies, and then you get put into a management or a development role, and you don't get the training for it necessarily. And that's why I've asked the question about how many jobs have you got being done by paramedics that actually could be done and perhaps should be done by somebody who's better trained.
Thanks very much, Peter. And certainly from my perspective, community first responders as an issue is certainly it's going up the scale in terms of priorities. I'm certainly interested to learn more about that and how it operates, and how we can take greater advantage of it. Thank you very much for that. Any further comments or questions? This is one of these areas where no is not a particularly good answer.
I don't know whether you're completing the questions, but I have one about this meeting, if you'd like it now or at the end.
By all means, now.
I should have, and I apologise for not saying earlier, Michael Taylor, user group, and shadow governance. Regarding this particular meeting here, I'd like to congratulate the staff on getting the papers out earlier than normal, because quite often we don't see them until we arrive, and people like us and Pam like to see these things beforehand. But on this particular one, on this venue, we did have difficulty getting in. As you see, we have a wheelchair person here who couldn't get in here. A number of us arrived and said, oh, the car park's up the road. And I just wonder if a little bit more attention could be And I don't like criticising on venues and where you meet, because you've been to some odd venues in the past, just so that when there's a wheelchair coming, there isn't the panic of getting wheelchairs up and down steps around here to get in here. So we do apologise for arriving late, because we had a huge job and the car park up the road was full.
Mike, I'm really sorry to hear that, and no reason for you to apologise at all. I'm sorry that you had that inconvenience, and Julia, I'm sorry that you had that struggle. It's no comfort, but I can tell you, for example, even when I was at Stoke Mandeville, having a meeting organised at a facility where there was no access for wheelchairs. And I'm thinking to myself, how can that be possible? Having said that, I can also say that actually that Sue and her team spent quite a lot of time, effort and energy trying to find a venue in Bedford. So, but I wouldn't want you to think that it was sort of last minute or plucked out of the hat. There was actually quite a lot of work done to try to find somewhere that was an ideal venue, and we'll continue to improve on that. Just on the papers, thank you for that, and I think it is a fantastic effort, Sue, through you to the team, to get that together, and to get it together in a timely and well-organised way. So thank you very much for that. It is my ambition, and I've done this elsewhere, to move on to a digital platform, so that we'll be sat here with iPads, not playing Angry Birds or whatever, but actually able to access the papers on a server, and indeed papers would be publicly accessible as well. So you won't need to ship this collection around. You'll have access to what you need digitally, and that, you know, people sort of sometimes welcome that and sometimes think, well, actually I quite like scribbling in the margins and turning the pages and all that sort of stuff, and there are still ways in which you can do that, so don't be alarmed by it, but certainly you can imagine when I was chairing the board of NHS South of England, with all that entailed, to try to do it on paper would have just been I think unworkable, and we did actually successfully move that onto a digital platform, so that can get even better too. But I do appreciate your comments, and thank you very much for that. I'm pleased it worked well for you. Okay, is there anything else? Yeah.
Colin Walker, Suffolk Health Scrutiny Committee, and also Great Yarmouth and Waveney Health Scrutiny Committee. I'm a district councillor, elected member. Now, there's a reference in the papers this time to the CCGs, and whereas you had the NHS Suffolk in the first instance, you've now got 2 CCGs to contend with in Suffolk. But democracy is round the corner. Elected members are very, very interested in the ambulance service, and I've been coming to your meetings now for 4 years, and I've always been considered to be a member of the public. I have to stand for election every 4 years, and I do work hard at doing that. And there are other areas now that need to be considered, and that is the health and well-being boards. There's been no involvement up yet, as far as I know, and I have written to the chairman, and I've said, where does this stand with the ambulance service? Haven't got a reply to that yet. And of course, as I mentioned, there are the health scrutiny committees where I report back to after these meetings. But we would dearly like to know more about the ambulance service. We had a bit of a failure a month or 2 ago when we felt that the wrong level of management actually arrived at our health scrutiny committee meeting at Ipswich. That was very, very regretful, but on the other hand, we do need to speak to the right level of managers in the ambulance service. Now, we're meeting again in July at Ipswich, and also at the meeting of the Great Yarmouth and Waveney Health Scrutiny Committee within the next few days.
Colin, thank you very much for that. A couple of comments, then I'll get Andrew to comment. Certainly from my point of view, the changes you allude to in the commissioning architecture of the NHS, whether that's CCGs or health and wellbeing boards, I think we've yet to see how that will settle down and work together. And when I look at what it is that health and wellbeing boards are intended to do, it's clear that they're going to have a pretty good flow of information, not only about the service today, but also about what the shape of things to come, what that should look like. And interesting, as I was doing the rounds of local authorities over the last 12 months or so, what I found interesting as the shape of health and wellbeing boards and their role was being defined, I was finding that local authority chief executives were asking me about what they should do. And I'm saying, well, hold on a minute, this is not about you, this is you who are going to be taking leadership of this. And it does seem to me there's a risk of a bit of a leadership space opening up there, if we're not careful, with CCGs very much locally focused, strategic health authorities no longer there, and health and wellbeing boards perhaps still shaping what it is that they're doing and how they're going to do it. So there's a little bit of a sort of leadership space there if we're not careful. So I'm with you in terms of making sure that both health and wellbeing boards and indeed the health overview and scrutiny committees do get the right level of engagement and presentation and flow of information to enable them to do the jobs that they're being asked to do. And, sorry.
Just a quickie on the Suffolk overview and scrutiny. I'm pitching up at that one in a couple of weeks' time or whenever it is. So hopefully that will allay any fears about levels of seniority attending those. Normally I try to get to as many as I can. It's usually either a diary commitment or a conflict that two people have them on the same day and only be in one place at a time. So just to reassure you on that one. Yeah, health and wellbeing boards haven't been on the other side of the sort of table, I suppose, having been a commissioner up until fairly recently. I sensed a number of health and wellbeing boards were not that keen to have providers as they saw it attending. They wanted commissioners, they wanted the voluntary sector, and they wanted councils to be attending. I think a number of us did say at the time, well, if you wish to exclude the people who provide the service, don't be surprised if your plans fall down somewhat. Because you won't be talking to the right people. So absolutely support the line that not only should we be invited, as it were, but we should be knocking on people's doors and saying we think we can help you do your job better if you allow us to attend your health and wellbeing board. So I think both of those points very gratefully received. Thank you.
There's 21 members on the Health and Wellbeing Board. 2 of them are policemen. You'd be very welcome, I feel sure, if you came along.
Hi, I'm Celie. I'm the policies lead for the Trust. I just wanted to comment really in terms of the overall sense of what's been discussed today, and very keen to the clinical leadership that we're showing. But just not a sense, I don't get a sense of how we feel as an organisation, as the ambulance service, are addressing the wider health inequality issues. And I know that Phil mentioned this earlier, but also that it's, and I know we are at this board level and strategically looking at figures and outcomes, but I don't get a sense of the dignity and compassion, which I think was picked up a little bit actually in the comment about handovers, and it's about that dignity and compassion issue that we don't seem to be, I don't get a sense of it, although I think it may well be there, but I don't get a sense of it, and I wonder if that is something that we can enhance further and report more around health inequalities and how we as a service are impacting on the region and the wider health economy.
I accept all of that. Thank you for the question. On the sort of compassion and dignity bit, I mean, certainly when I'm out and about talking to staff and others, a bit like the chair talked about safety, quality and money. When I talk about responses to patients, I mean clinical quality, that we send people who are competent, that we treat people with dignity and respect and compassion, and we get there quickly. So a bit like the old one-armed bandits, unless you get all 3 of those lined up, you don't win the jackpot, as far as I'm concerned. Now, I think you're right. Today we've probably focused on the clinical quality bit, and we've focused on the response time bit. We probably haven't done that middle bit in the sandwich, the bit about compassion and dignity, and I suppose just that TLC and the caring bit. And it's one of the reasons why we've encouraged colleagues to go out to control rooms, go out to officers, go out on ride-outs, because you see it in action then. You see all of our staff really showing that on a day-to-day basis. And you might have seen a number of us when we're out and about tweeting now of, out to job X, seeing person Y. What comes through on all of those is the fantastic care and compassion that our staff show. I don't know how we portray that effectively in our discussions as a board or in our papers, but I will accept the challenge to see how we actually do that. On the wider health inequalities bit, it probably goes back to the last question around health and wellbeing boards. That's absolutely what they're about. That's, I think, on all the ones I've ever been to or been on, that's what they do, and that's why we need to be around that table as well. I think it is about what overview and scrutiny committees are interested in, unless I'm about to go to one that isn't interested in that. I'd be amazed if I was. And again, I think we do a lot that we could relay back here as a board, so I'll accept the challenge of can we do more on that.
Thank you. If I may just make one further comment before I come to you. Just for the avoidance of doubt, from my perspective, you're right, there has been and will continue to be, I think, a necessary focus on the harder edge performance parameters, safety, quality, money. But thank you for the challenge, and I certainly accept that in terms of making sure we demonstrate alongside of that continuing compassion. What colleagues won't know is that over the last year I've chaired a regional conference on dementia, for example. I've chaired a regional conference on health and learning disability, and of course I have in the past chaired a mental health trust. So in terms of equality in healthcare, it's very much central to what I have done and continue to do. But thank you for the reminder, just to make sure we're explicit in making that clear, that we're very much paying attention to that dimension as well. If it doesn't come through, it's because of the need to be really clear in terms of the harder edge performance parameters that we do need to deliver. Doesn't mean to say it's not there. Neil, did you want to comment?
Sure.
And I'll come to
I might just add to that in terms of context. I think what's really important in terms of the wider equality issue as well is to reference our clinical capacity review and just remind the board and colleagues that as part of that, we as an organisation were very clear to say we wanted to deliver all standards to everybody in our region. Now that's an ambitious challenge, but that's the ground rules absolutely of that modelling and that external piece of work that's working with the organisation. Now that is an ambitious challenge and one we're working with CCD colleagues on, but it's very much an equality issue as well as a service delivery issue. So the two are very much hand in hand, and that output of that clinical capacity review will very much address some of the equality issues across our patch.
Yeah, thank you very much. Okay, last question.
It's not a question actually, it was to add to the last point. My name's Alan Harpham, I'm chairman of Workplace Matters. This is an ecumenical charity that provides voluntary chaplains to various organisations in the workplace, and we provide a number of chaplains in Bedfordshire, I think one in Hertfordshire. We'd like to do more. The point I wanted to make is that I think your people are absolutely wonderful. The degree of compassion, dignity they show to the patients when I've been on ride-outs is amazing. I'm sure Linda, my colleague, would agree totally. So I just wanted to reinforce the fact I think you're very good at that particular thing. I don't think people could do that job if they needed training in that arena. I think they come with that in spades. Thank you.
Well, that's lovely to hear. Thank you very much. I actually chair a multi-faith group of healthcare chaplains myself, which has, I must say, provided a platform for some very interesting discussions about how you provide multi-faith chaplaincy through what is a very diverse community. But thank you very much for your comments. Appreciate that. I think I'm going to close the meeting on that point. Listen, just to say thank you very much to all of you for being able to be here today. Much appreciated. And I think I need to just to check, is there any other business, any other urgent business at all that we need to pick up on just now? If not, thanks all very much. And to note the date of our next meeting, which is the 31st of July at 11 o'clock, and then the annual public meeting at 2. And that'll be at the Trust Headquarters in Cambourne. Okay, good. Thank you very much indeed. Thank you.